So some general principles, once again, is that care needs to be individualized based on the presentation and issues which are specific to the individual patient. Some infantile issues are very important to recognize to ensure a good outcome. For instance, the cardiac, feeding. You know, if you do not pay attention to the feeding, you may have a wonderful response to enzyme therapy, and the child may just aspirate and not make it. So this is just to say that the team approach is very good, recognizing each one's experience and expertise to provide comprehensive care. And rapid diagnosis and early treatment is a key, but I will state again, it's not the complete answer to success. There are some who start really early but still do not have the optimal outcome, and I think those are things that we have to learn. I think there are different situations and management, and once again, I'll focus on the infant, but I think this also applies to adults. So a child that's newly diagnosed and stable, a child at follow-up and stable, is quite different from the child who's newly diagnosed, but in the intensive care setting. What do you do? When do you do? And should you do anything? And then the child who at follow-up is not doing well, so was initially doing well, but now is not doing well. Or the child who's doing well but has an acute infection now and is now in the intensive care. I think these are all individual situations, and to generalize is very problematic. And this is where the experience and expertise of the physician needs to come in. Line access, a classic example. We recommend you do need line access. It's often a problem. Do we really rush into it when the child has this huge heart? No. You can wait. You can do peripheral IVs until the child is more stable. It's a little more trouble, but it doesn't mean you go and put the child at risk for anesthesia. And so the risk-benefit ratio of each and every decision that we make, I think, should be done at the outset. So in terms of the cardiac issues, I think for the intensivist, or if the child is in the intensive care setting or even is being recently diagnosed, recognizing the stage of the disease, whether it's in the stage when the muscle is really hypertrophied, to the stage when the heart is now dilated, or to the stage when the heart is now in failure, I think really is very important in terms of what you do in terms of managing the heart outside of ERT. There is an abnormal conduction system. This is in infants. It's a smaller issue in adults, but it could be an issue in adults. But understanding this, I think, is important again. What medications can you give? For a simple cough and a cold, if you've got an abnormal conduction system, you have to limit some versus not. So knowing the whole picture, knowing that is really critical. The other part, I think, that was brought about yesterday by Dr. Jones, and I was not there for the presentation, but he kindly shared it with me, was a drop in the ejection fraction. Enzyme is doing great. There's a remodeling process that's going on. There's a drop in the function of the heart, not because it's failing, but because it's now adapting to its new environment. You need to look out for this. If you don't, you can really lose the child. So these are the aspects that I think are very important, and this has been shown in the clinical trials. Here is the normal ejection fraction. Over time, it's coming down, as you can see on therapy, and then it comes back up. So providing the support at this point is very critical, because you can get through the stage or you can lose the child if you're not thinking about it. So what I'm saying is keeping up and trying to figure out what's going on is very, very important. Talking about the stage of the disease in the intensive care unit, they're used to treating cardiomyopathy. But this is not just any old cardiomyopathy. It's important to determine the function, whether the child has what we call a blockage or an outflow tract obstruction. You use certain drugs only when there's a certain situation. If you use them in another setting, they really can be harmful. Anesthesia, once again, the same thing, understanding, and this applies even to the adults. For the child, really, we try and say avoid the intubation in the early stages as much as possible, because they are so weak, some of them, that trying to intubate them, yes, is easy, but trying to get them off the ventilator is very hard. For the adults, it's a very difficult situation. But once again, thinking through the situation, when the child is now in the intensive care setting, you're trying to do a procedure. Does that procedure need to happen now? Can it wait? Can you go by with a regional block? I think those are the situations that we have to understand and recognize as we manage the infants with Pompe disease. Pulmonary, once again, a simple test. Difficult to do in the infant, easier to do in the adult, but yes, there are limitations at both ends. Do what's available, do what's practical, do what you can even in the intensive care setting. But in terms of doing infant PFTs, if it's at a center that can do it, do it. Do blood gases. If that's not available, do something else. Try and figure out what's applicable to the situation, but do what's right for the intensive time that is. I think this was brought about yesterday. Oxygen. Everyone thinks this is like food. It's not. It can be very harmful to the child. You've really got to think, does the child need that oxygen? Put them in the intensive care. The first thing is put them on oxygen, whether it's really needed or not. You may get by with just positive pressure ventilation. You may not need that supplemental oxygen. So really thinking carefully is very good. Management of the pulmonary infections should be very aggressive, not just for the infants, also for the adults. Routine clearance of airway secretions. Frequent suctioning to avoid excessive buildup of secretions. Very good chest PT. And I can't tell you how much Laura has helped our children in terms of helping with fighting infections just by vigorous chest PT. Use of devices like the cough assist device. What medications are we using? And I think this applies even to the adults. What kind of bronchodilators are we using? Are they really good or not? For the infant, clearly, you have to stay away from those which stimulate the heart. You make the heart go faster. You're improving the lungs, but you're worsening the heart. So it's really a balancing act and trying to work through this. I think Sonia talked about this, about the swallowing difficulties and feeding difficulties in the infant. So I'll go past it. Osteopenia, once again, quite common now, as we are seeing. It's being recognized as a prevalent issue in Pompe. It's observed in both infantile as well as the late onset cases. Is this treatable? Yes, it's treatable, but if you don't look for it, you're not going to treat it. A number of individuals doing well on enzyme therapy, more mobile, wanting to walk more, have weak bones, not being looked at, fall, break a bone. So you really have to think through the issue. Children in the ICU, the intensivist focusing on just the heart and the lungs, not focusing on the fact that the child may be weak. We've had at least 3 fractures in our intensive care unit just because of handling of the child. So really taking these considerations as we monitor is important. And this is something that we had published then, is weak bones and a fracture. And yes, these are all fixable. And actually on ERT, the bone density can improve. The child becomes more mobile. There's more weight bearing. But once again, working with the physical therapist, what exercise is good enough? What's too much? The kind of exercise all needs to be put in perspective. Management, yes, the child may be in the intensive care, but do not forget to treat the child as a whole. Strict hand washing, aggressive management of infections, routine immunizations, doing the flu shot, taking careful use of the over-the-counter and other concomitant medications. So these are also very applicable to the adults. So I tried to steer this to both. Delivery of enzyme therapy. It's not just giving a protein. Yes, we're going into home care, but really there needs to be the appropriate facilities to deliver the enzyme. The nurse needs to be at the home setting throughout the infusion to make sure things are going well. A good knowledge of when to infuse and when not to infuse. If the child is acutely ill and has been on the enzyme therapy for a period of time, it's okay to skip a dose. It's not worthwhile to give so much protein at a time when the child is vulnerable. In an example, again, in the intensive care setting, you may have to think through that as you're doing it. A good knowledge of how to manage the infusion-associated reactions. They occur not just in pediatrics, they also occur amongst the adults. In fact, we are starting to recognize this. We don't have to be frightened, we have to work through it. It's very possible. It's what we call give the protein at a smaller rate, smaller intervals, and we've been able to, what we say, desensitize the patient or bring them back to get the full dose of enzyme. Please follow the antibody titers. I think it's a very important component of care in Pompe disease, not just in the infant, but also in the adult. I think this is going to be of value, and I'll go through this. In the intensive care setting, careful administration of fluids, overhydration is as risky as keeping the child dry.